Now I would like to request Dr. P. Krishnamurthy sir to honor the speaker and the chairpersons.
Let's start with the second session. The importance of good antenatal care in pregnancy could not be overemphasized. It links the mother and her family with a former health system, increases the chance of skilled attendant at birth, and contributes to good health throughout the life of a woman and the child. Topic is antenatal care. What best we can do when to seek expert help.
The chairpersons are Dr. Ramya G. She is DNB Family Medicine, Fellowship in Diabetology, current State Treasurer and Academic Coordinator in AFPI Tamil Nadu, Organizing Treasurer of AFPICON Tamil Nadu 2022. She is currently the Consultant Family Physician at Rams Neuro and Family Healthcare Clinic, Chennai, Consultant Family Physician at Vinitha Hospital, Chennai. She is passionate about teaching, learning, academics, and connecting with people. Dr. Subramaniam, he completed as a UG at Stanley Medical College, DNB Family Medicine at Indira Gandhi Government General Hospital, Pondicherry, got Best Medical Officer Award from Pondicherry Government, currently working in Newborn Care Unit in Rajiv Gandhi Government Women and Children Hospital, Pondicherry.
The speaker for this session is Dr. Padma. She has completed her MD DNB in Obstetrics and Gynecology and Fellowship in Gynecological Oncology from Netherlands. She is the Senior Consultant and HOD of Department of Obstetrics and Gynecology, Meenakshi Mission Hospital and Research Center, Madurai. She is a laparoscopic, hysteroscopic, robotic surgeon, gynecological oncologist, maternal and fetal medicine specialist. She was the Treasurer of Madurai Obs and Gynae Society 2019 and 2020, past President of IMA Madurai Meenakshi Branch, and past Joint Secretary of Association of Gynecological Oncologists of India. She has organized many local laparoscopic, gynecological oncology, urogynec, and fetal medicine workshops. She has presented a guest lecture on PPH at SMFM Conference USA and also presented a paper at World Endometriosis Conference USA. Thank you.
Good morning, every one of you. And it's quite heartening to see the hall full early in the morning. So I know family physicians are always at work. Thanks for that. And at the outset, I would like to thank AFPI and the organizers, especially Professor Krishnamurthy sir and Pranitha for this opportunity. And when Pranitha called up and said that we have to talk about antenatal care, and having worked in a tertiary care center like Meenakshi Mission for the past 25 years, I was just contemplating where do I start. And a small introduction of my work here. Nearly around 80% of the patients who come here are high-risk patients, and nearly around 40% of them are late referrals. Almost they come at the time when they are too sick or they are already needing multi-speciality care. So with this background, I'll just start my talk. So what do you mean by antenatal care? Antenatal care is nothing but a systematic supervision of the woman during pregnancy at regular intervals to monitor the maternal well-being, the fetal well-being, and the progress of the fetal growth. So why do we need to have an antenatal care? The most important, the reason being, there should be a birth plan for every woman who gets pregnant. We need to know where she has to deliver, when she has to deliver, and how she needs to be delivered. And so we should start by providing a quality care for the well-being of the pregnant woman and the fetus. And we should be in a position to identify the complications, both for the mother and the fetus, and identify a facility for referral for the particular problem the patient has. And from a pregnant woman's point of view, all she wants is a positive pregnancy experience. And this positive pregnancy experience, at the end of it, she wants to have, she wants herself to be healthy and have her hands full with a healthy baby when she goes home. And she wants this in her own physical and socio-cultural environment. And the transition towards the labor and the postnatal period also needs to be smooth. So in this context, there are many professional bodies who have come out with their own care packages, and WHO also has a similar care package, which it has revised in 2016. And what it stresses is the aim of this whole antenatal model of care proposed by the WHO is to provide a pregnant woman with a respectful, it's very important, a respectful, individualized, person-centered care. Not two women are the same. We all say, no, anju veralu ore madiri illa. Same way, every individual pregnant woman is different, and the care should be person-centered. And this has to be given by practitioners with a good clinical skill and interpersonal skills in a well-functioning health system. I'll just come to that shortly. So ANC care is critical because it reduces the complications of pregnancy and childbirth. It reduces the fetal complications like stillbirth and perinatal deaths, and it should be an integrated care delivery system with the appropriate specialist care as and when the time warrants. So historically, when you look into antenatal care, nothing was in place until the 19th century, where the only care the woman received for her pregnancy was in delivery was at the time of the delivery itself. But then subsequently in the 20th century, to bring down the high maternal mortality and neonatal mortality which was involved in the earlier centuries, an antenatal schedule which was roughly proposed, and we all have attended our medical school and grown through this kind of a schedule. So at least the emphasis was that at least the first antenatal checkup should be at 16 weeks, and then after that a monthly thereafter, and then once you reach the third trimester, fortnightly, and then the last month, it's weekly visits. But however, when we look into the medical literature, there has been no scientific basis for this kind of a callback. So that was the system that, slowly it was improved, and then the 12 weeks visit also came into work. But absolutely this has got no scientific value for that. But when you see even the previous one, the number of visits were too much. And that puts so much of a pressure on a system, especially in the low and middle income countries, where there is no proper primary healthcare system in work. So WHO, considering all these things, proposed a system where there should be at least minimum 4 antenatal visits during the pregnancy. But that system was little changed in the 2016 model, and they came up with the model which right now is in vogue. That is, the first contact should be within the first 12 weeks, then the second one at 20, and thereafter a little more frequent, minimum of at least 8 visits. The 4 became 8. That was because many of the complications was missed in the 4-stage system. Now, as rightly as Dr. Rajkumar said, in our system, what is happening is the healthcare system is like this. Headache, patient directly goes to the neurologist. And some other problem, they directly go to the super specialist. I wouldn't blame anyone. You practice every day what you are aware of. So when a patient goes like that to a super specialist at the right go, it is like the analogy will be like 7 blind men palpating the elephant to find out what it is. So the real care gets missed there. So the system which is ideal would be this, where the base is comprised of the primary health care and prevention, and then slowly the tertiary care is limited only to a small group of people who really need it. And the fault here is because it is very difficult to shift the real problem out of the total, husk over there. So even in the care of hands of a good super specialist, sometimes the caseload is so much, the real important patients who need care get missed out. So, and I'm really happy the state government, especially Tamil Nadu government, has taken up initiatives like Veedu Thedi Marthuvam and all those things to strengthen our primary care. Why I say this is, antenatal care is a physiological phenomenon. Every woman or every living being reproduces, and pregnancy care is a primary health care. But however, for a small group of people, that may not be sufficient, and a little more specialist care is needed, and a very small fraction of them really need a tertiary care or even a quaternary care to come out of the problems which they face during pregnancy and to get home alive with a good baby. So though all the mothers and children are vulnerable to disease or disability, there are certain mothers and infants who are at an increased risk or special risk of complications during pregnancy or labor or both. And we desire to improve the obstetric results. This group must be identified and given the extra care. So when you look at the causes of maternal and neonatal mortality, the big fraction of it seems to be arise from in the hypertensive disorders and then the bleeding disorders, and of course unsafe abortions, whereas the other form the rest. And when it comes to neonatal mortality, the majority is because of preterm birth and to some extent congenital abnormalities, and nearly 1/4 of them are because of intrapartum complications, that is failure to monitor the baby during the process of labor and then having intrapartum stillbirths. And what we need to remember is, for every patient who has a mortality, there are nearly 10 patients who have a near-death experience. So that needs to be remembered. Though they don't add on to the statistics of maternal mortality, both the patients and the treating medical team go through a lot of anxiety so that they are pulled out of that death-like situation. So that needs to be remembered when we give an antenatal care. And what are the good quality antenatal care components? One is a proper history taking, a thorough physical examination, obstetric examination, and appropriate laboratory investigations. I wouldn't stress much on the history taking and the physical examination. I just want to share a clinical situation. We had a young girl who came to us at around 22 weeks pregnant, 22 years of age, and she came to us for an antenatal checkup. And in our system here, we have the postgraduates and medical officers who take a proper history. The consultants examine them, and then we take appropriate action. And this patient, literally the postgraduates spend around 10-15 minutes with every patient to take a proper history out of them. A proper obstetric history, a proper medical and surgical history is taken out of them. And this particular patient, she didn't reveal, it was like as if there was nothing wrong with her. And then when we put on to the examination couch and when we examined her, and it's a part of our own, examination system, we give emphasis to the breast examination, irrespective of the gestational age the patient comes in. The first visit, the patient has gets a thorough examination of the entire systems. And luckily the consultant, she examined her, she saw a sternotomy scar. And had we not examined the breast, that would not have come. And when cross-questioned, then she said that she had undergone a mitral valvotomy as a child. And when we asked her why she didn't reveal it, she said, I was scared of my mother-in-law, and who was by her side when she came for her first antenatal checkup. I have not told them. My husband knows about it, but my in-laws don't know about it. So these are all things which are important. And so she chose not to open up. And that is the importance of having a confidential talk with the patient who walks into our OP at any time. Many things they may not even like to reveal to their own family members. And that is the importance of having a proper examination of every patient who walks in. And a proper, whatever I said, if we do that, then we'll be in a position to pick up the risk factors in this particular pregnancy. And the risk factors are many, and a few of them are the maternal age. And we still do see, in spite of so many government rules saying that the marriage age should be 18 and the pregnancy age should be 20, 21 and all, still we see, at least in this part of the country, in Madurai, the girls get married quite early. 16, 17 is a common thing. And even my own servant maid is saying, I am feeling a little, she's just 40 and she feels that she's old enough and that she's planning to marry her daughter off at 16. That was a conversation we had a couple of days earlier. So these teenage pregnancies, they are a real high risk. And the other extreme is, nowadays with advanced medical care, we see women who are 40 plus coming out with pregnancies following ART, with IVF, ICSIs and all. So they come with their own bundle of problems. So extremes of age is an important high risk factor. And of course lifestyle choices, though we cannot just brush it apart, because there are quite a good number of ladies now who are addicted to alcohol and smoking also. and we need to remember that. And of course, the medical history, I cannot insist more, surgical history, the previous surgery she has undergone, and the pregnancy complications. Pregnancy complications, as the pregnancy advances, needs to be picked up. And of course, the multiple pregnancy. So there are a number of scientific criteria which have, societies which have come out with criteria to pick up these women who are at high risk, that the risk assessment scores are there. But when you look here, as far as the obstetric history is concerned, when you look here is, they have given so much of importance to previous history of stillbirth and neonatal death. Same way for a premature infant who is born too early or an infant who is born too late. And that is much more than even the other scores for the other things. And of course, this fetal blood transfusion and for hemolytic disease is quite a, I would rather say it is a tertiary care event. And here, of course, luckily in this part of the country, the the number of Rh negative pregnancies, Rh negative population is much less. In the north, it's somewhere around 12 to 15% of the population are Rh negative, but here it is around 3 to 5%, which is much less. And because the healthcare system here is a little better, even in the PHCs, doctors know that if an Rh woman with a Rh positive husband, she has to have a anti-D injection at the end of any pregnancy event, be it delivery or even an abortion, and even ectopic pregnancies. So because of that, we are not seeing much. But of course, in the we have treated at least half a dozen cases in the past where we have even given intrauterine transfusions. So that kind of a care is also available for this group. And now coming to the medical history, and the most important thing is we need to identify all these things: chronic hypertension, heart disease, especially NIHA more than class 2 and 3, and insulin dependent diabetes, severe renal disease, endocrine problems, and all the other hemoglobinopathies. They are all quite high risk factors, and then they have a large say in the maternal outcome. And the other risk factors being, during the pregnancy, any woman with a uterine malformation or an incompetent cervix is a very high risk for a preterm delivery or an abortion, mid-trimester abortion. And so that increases the risk care points. And in the current pregnancy, the most important being the antepartum hemorrhage, multiple pregnancies, and the woman who develops severe preeclampsia, and any abnormal fetal position or presentation. All these are high-risk factors which need to be identified, and the delivery should happen in an appropriate healthcare center. So based on all these things, this is yet another scoring system. There are different scoring systems available, and we can choose what we need to according to our own convenience. And once again, the triaging should happen as to where the patient needs to deliver. So now, as I told you, the initial health, the system as of now which is in vogue is this. But what has been proposed as an ideal antenatal care system is this one, where the evaluation of the fetus as well as the mother happens by as early as the end of the first trimester itself, identification of all the maternal risk factors, and then those people who really need a specialist care or a tertiary care get referred to the adequate centers which are capable of offering it, whereas the rest form the general pool, and they can very well be safely in the hands of their family physician or a general practitioner. So, in an ideal world, the antenatal care starts even before pregnancy itself. A pre-pregnancy care is very, very important, and needless to say, many of these high-risk patients, like now with advances in medicine, we do see patients with even complex congenital heart disease getting operated and getting pregnant. So everybody wants to have a normal life as possible, and there is nothing wrong in having a desire like that. But as a medical personnel, we should be in a position to help them out. And so identification is very, very important. And at this point, I would like to stress there are good number of people now with early onset diabetes, especially with PCO. PCO now is a lifestyle disorder. And when these kind of girls come to us, we need to give them suitable advice, like what kind of a control should be, diabetic control should be, because diabetes not only affects the mother, but the embryopathy associated with diabetes is quite early. And for this reason, there should be a good diabetic control. And before a girl with diabetes plans for a pregnancy, her HbA1c level should be really ideal. And same holds good for people with other medical disorders, because it's a tertiary care center and our nephrology department does even renal transplants. We do get patients who are on post-transplants. They come to us for pregnancy and delivery. So in this group of people, they are on certain drugs to especially like ARB inhibitors and all those things. Those drugs needs to be changed into a more appropriate drug before they plan out a pregnancy. So that is the importance of a prenatal care. But then that doesn't happen, and that is the real practical world. And the first time the girl ever comes for a medical checkup or evaluation is during the pregnancy itself. There may be a pediatrician or a neonatologist has examined her at birth, and a pediatrician has given her immunization schedule and care. Beyond that, they would have never gone to any doctor. And the first time she ever comes to the hospital is when she is pregnant. So I always tell my PGs, we are basically doctors first and then specialists. So we, as a obstetrician, we first need to examine the patient as a whole, evaluate her as a whole, and pick up any medical problems are there, and then offer the necessary antenatal care. So we have to use that window of opportunity. Having said that, not all women start the pregnancy with a problem, but then problems can happen as the pregnancy goes on. And the most important thing all of us are aware of is preeclampsia. And so do we have any screening tests for that? Yes. Now we do have it, and we need to offer these kind of screening tests to our women so that they don't end up in the high-risk group. So this concept of this reversed model, or inverse pyramid, was actually proposed by Professor Kypros Nikoloides of UK, and many of the societies of advanced countries, the obstetric societies, have taken up as the model of care. And the aim of this care in the first, picking up all the problems in the first trimester, they include the early screening for fetal aneuploidies. And aneuploidies, you may think why. But then if you look at the statistics, nearly 1 in 500 pregnancies, they are aneuploid. But luckily, nature is a good doctor, and most of these pregnancies get aborted. And it's only a small fraction of them they go until term and deliver. But we need to know such an aneuploidy exists, and an early diagnosis of fetal abnormalities is very important, equally important. We have no justification in making a woman who is a high risk for pregnancy, asking her to carry an abnormal baby till term and then say the baby is abnormal and it was all a waste of effort. That's not acceptable. And the early screening of miscarriage and stillbirths, early screening for preeclampsia, small for gestation age, and preterm delivery. And our own Society of Foxy has incorporated this in its protocol for antenatal care. Though these are all the regular routine tests we do for everyone, this special mention is at the period of 11 to 14 weeks, which is very important, and we need to screen for all these factors which I just mentioned. So when we talk about prenatal screening, it is all about ruling out aneuploidies, anomalies, and to rule out preterm births, which woman is likely to go for a preterm birth, and who are the people who are likely to develop preeclampsia. We'll just see one by one. So sometimes in our clinical practice, when we sit down, we see a woman coming up, when she comes to us, refer to us in the 3rd trimester for a delivery, we see she has got a big bundle of antenatal scans. But when we go through the records, we find that most of them are being taken in the later weeks, where the emphasis is there on the earlier weeks. So that is why in this pyramid we have the big chunk of it being given for the 11 to 14 weeks ultrasound. And in that period, I'll just come to it shortly, what needs to be checked, I'll just tell you. And the other important thing is this should never be missed. Even if this is missed, this needs to be done. A proper anatomical survey of the baby is very, very important to rule out any anomalies, and appropriate care needs to be given. The government has been quite kind enough, because initially the cutoff for MTP was around 20 weeks, and a majority of the times a proper antenatal scan to rule out a reasonable number of anomalies is possible only at the end of 19 to 20 weeks. And with that cutoff of 20 weeks, it was like so much of a pressure on the sonologist as well as the obstetric caregiver to pick up anomalies, and of course it gave a lot of heartburns also. Now the time frame has been shifted to 24 weeks, and we are able to give a better care. So when we are able to pick up anomalies, then we need to divide them into anomalies which are compatible with neonatal life and those which are not. But even then, we need to give the necessary information to the patient, and they need to choose whether they want to continue the pregnancy or not. Time and again, we have patients who come to us with minor anomalies like a club foot or a cleft palate, and when we say these are all, we don't have to terminate the pregnancy for that sake, but for that particular family, they are very particular that they want it terminated. I sometimes don't understand, but once again, we are not supposed to judge the patient based on that. And when we have refused termination on these grounds, people have always gone outside and have got it terminated. That is how things are in the practical world. And the insistence is more on the third trimester scan also. At least, even when these two things are really good, at least one scan at around 32 to 34 weeks help us to identify those fetuses which are likely to go for growth retardation, and a good follow-up, and then deliver them in the right time. Many times we have seen this. When we don't give stress on this part of the scanning, what happens is the pregnancy continues, and these are the group who go for unknown or undetected or unexplained stillbirth. See, the placenta, like I always tell my patients, just like how drugs have an expiry, even the placental function has a limitation. When the baby goes beyond a particular weight and other things, the placenta may not be in a position to support that particular baby's weight, may not be in a position to provide the nutrition as well as the oxygenation needed to make the baby thrive inside the uterine cavity. And so that is the patients who need to be picked up and delivered earlier. So now these are the factors we have to check for in our first trimester ultrasound. The chromosomal disease markers, the most important being the NT scan. We call it as the NT scan, nuchal translucency. Nuchal translucency, I think most of you are aware, but then it is just a little collection of fluid at the nape of the neck which needs to be measured. And once again, for my postgraduates, I just in simple words, I tell them, it is just like evaluating an adult with a pedal edema. When a person presents with pedal edema, there could be a humpty number of reasons, right from head to toe. Similarly, when a fetus presents with an increased NT, there are so many reasons we have to think about and rule out. And the next important thing is the twin pregnancy. Twin pregnancy is not just simple twin pregnancies. There is the dichorionic twins and the monochorionic twins. Dichorionic twins are just like two siblings growing together at the same time in the uterine cavity, whereas with the monochorionic twins, it's a single embryo which splits and then goes ahead with the pregnancy. And then this monochorionic pregnancy, while nearly 2/3 of them do have a good uneventful pregnancy, nearly 1/3 of them go through a lot, and that is even, it's a handful even for a fetal medicine specialist to deal with. And we do, recently we do even have, advanced modalities like placental laser to separate these two fetuses, so that there is so much of intertwining of the fetal blood vessels. So one fetus becomes the pumping twin, whereas the other fetus becomes the receiving twin. So both the fetuses are at risk. So medicine has gone to that extent. So at least we should know what kind of twins it is, and then refer them for an appropriate center. And then once again, major anomalies, and then now coming to the preeclampsia screening and prematurity screening. So that is the NT I was measuring. So this every fetus with a crown rump length of 45 to 84 millimeters, that is exactly between 11 plus 4 weeks to 13 plus 6, that is the gestation age, where we have to check for this area, the small collection of fluid at the nape of the neck. We call it as nuchal translucency. And apart from that, the other things we look for is the nasal bone, the tricuspid regurgitation, and the ductus venosus flow. All these things are pointers for aneuploidies. So this is the screening schedule for an rule out aneuploidy. As I told, the incidence of Down syndrome is nearly 1 in 800. And though initially it was only based on the maternal age, that alone is not sufficient. Maternal age is just a priori risk. And when you see by the sheer number of pregnancies happening in the younger women, every pregnant woman needs to be screened for aneuploidy, because most of the pregnancies happen in the younger age group. And the pointers we need to identify are the ultrasound and the biochemical factors, based on which this a priori risk gets modified. And those people who we identify as high risk should go in for a more invasive testing. By invasive testing, we mean amniocentesis or chorion-villus sampling to assess the fetal chromosomal pattern. So how it goes is, based on the ultrasound and the serum, maternal serum biochemical markers, we classify them into a high risk. That is more than 1 in 250. What is this magic about this 250? That came in because when we do an amniocentesis or a chorion-villus sampling, there is a small risk of pregnancy loss associated with the procedure itself. And that risk is around 1 in 250. So whenever we do a procedure, it should be justified. The risk benefit should outweigh the risk. So only at that statistical point, the advantage of having an amniocentesis overweighs the risk of losing the pregnancy. So that has come in as the cutoff. And when the risk is more than 1 in 1,000, then there is a very, very unlikely chance of the woman carrying an aneuploidy baby. But in the in-between risk, we do have further modalities of testing like NIPT, and these are also screening tests, but then they have a very high sensitivity. I won't go into the details of it. So apart from the, the aneuploidies, these first trimester markers also help in identifying the pregnancies which are at a higher risk of pregnancy loss. So these are the proteins we check for in this serum, maternal serum. So the different conditions can be picked up based on the levels of these serum markers. So, and once again, now with advancement in imaging, nearly around 70%, though the time frame is around 19 to 20 weeks for picking up abnormalities, with a better machines and imaging facilities available, even now nearly 70% of the anomalies can be picked up as early as the first trimester itself. So that is all a 3D picture of a fetus. So, and another point of caution is, many a times the fetus is evolving situation there, and anomalies which don't pick up in the first and second trimester can get revealed in the third trimester. And some of them, like achondroplasia, skeletal dysplasias, initially it's very difficult to pick them up in the early weeks of gestation. Same thing about the CNS anomalies like absent corpus luteum, corpus callosum. So all these things are very difficult to pick up in the early weeks of gestation, and they get picked up only in the last trimesters. And when, I'm just putting this here because as a group of family practitioners, you may have your relatives and friends coming and showing you scan reports saying that initially they said the scan reports what was normal, and now you see what has happened. It is not so, because not all anomalies can be detected in the first and second trimester, even though the fraction which gets revealed in the last trimester is less. Still, a good number of anomalies do get picked up in the last trimesters as the organ development evolves. So whenever there is an anomaly or an abnormality which is picked up, then we need to go behind the genetics behind that. And for that, we can do either a karyotyping, a macro array, or a next generation sequencing, which is even sometimes beyond the comprehension of a regular obstetrician or a family medicine specialist. And we do have to take the help of a geneticist in solving these complex situations. So now friends, in the first trimester screening, the pathology of a good number of diseases do exist, and we need to go behind them and then pick them up, especially as the preeclampsia, diabetes mellitus, fetal growth retardation, and all those things. So when it comes to preeclampsia, the preeclampsia basically is an adaptive disease where there is a relative placental imbalance. And because of that, what is happening is the placenta is not okay formed, so the problem happens on both ends. The fetus on one side goes for a growth restriction, intrauterine death and other things, whereas the mother, because of a whole range of chemicals which are being released, goes in for a PIH and its associated complications. So basically PIH is a disease of the placentation itself. So these are all the factors which we take into consideration for screening, namely the maternal history, a patient with a previous chronic hypertension, renal disease, a patient with APS syndromes. They're all at a higher risk for developing preeclampsia, and the maternal blood pressure, and these are all things which are history and physical examination, whereas the other things are a little more complex. And so what we need to do is a first trimester Doppler of the uterine artery. So that helps with when there is a pulsatility index is abnormal. That is an important risk factor for picking up or predicting PIH in the long run, because the vasoactive substances are getting released from the improperly implanted placenta, and the maternal vasculature reacts to that, and that response is being picked up by this kind of testing, and of course the biomarkers which I just mentioned. So with a proper history, maternal mean arterial pressure, uterine artery Doppler, and the serum markers PLGF and PAPE, nearly 93% of the women who are likely to develop preeclampsia can be picked up. And when it comes to preeclampsia, there are two types. One is the early onset, which happens before 34 weeks, which is definite. The pathology behind that is the placental malformation, whereas the late onset, which happens after around 34 weeks, is little better manageable, because beyond 34 weeks, with the available neonatal system, the baby invariably survives, and the delivery becomes an easy option beyond that. So that is the sensitivity of the test. The pickup rate for early onset PIH is as good as 90%. Whereas even with this kind of testing, the pickup rate for late onset PIH is not good, because the pathology here is a little different from the pathology here. So once we pick up the disease, do we have an intervention to prevent the disease from happening? Yes, of course, we have this. Aspirin, sir had just mentioned that patients with early stroke, he just gave an aspirin, the patient was in a good shape. Same thing I feel it's a good drug for prescribing for a patient who is at high risk for developing preeclampsia, and the dose we need to put them is around 150 milligrams, and we start, especially for people who are prone for preeclampsia, like chronic hypertension, Napoleon syndrome, we start it as early as 6 to 8 weeks, as soon as the fetal heart appears, because we don't put it before that, because for some reason, if there is a missed abortion or the fetus doesn't grow, we may have to go for a termination. So the aspirin there delays the process. So when there is a good fetal heart and we know it is a good viable pregnancy, we start that. Or otherwise, when the patient is not a high risk and the increased chance of PIH gets picked up in our screening, then we can start it before 16 weeks. And because the placentation happens, the physiology of placentation happens before 16 weeks, any amount of drug we add after 16 weeks will have no effect or help on the patient. So whatever intervention we do needs to be done before 16 weeks for prevention. So that is the slide to show that when we start the patient on aspirin, the chance of early onset PIH has been brought down so much. There are multiple studies showing that. And of course, I cannot stress much on the APLA syndromes. And so if I would say it is like a big number here. So probably because it's a tertiary care center and we have a good hematology department, nephrology, and the other neurology departments here, we do see a good number of patients with APLA positivities. 1 in 5 patients in my antenatal clinic is a APLA positive patient. I know it's a very big number, and when I tell my colleagues outside, they say I'm pulling a fast one. But the situation is here. So why I say this is, it is not uncommon. And as family physicians, you need to think, someone who presents with an early stroke, or someone who gives history of repeated abortions, these are the groups which have to be counseled, and we have to seek for these kind of problems. And when identified and an appropriate treatment is given, these ladies too can have their nests full. And it's very rewarding to pick up, identify, treat these patients, and send them home with a healthy baby. And next comes GDM. And time and again, I think all of us have heard this, that India is the diabetic capital of the world. And 1 in 3 of our antenatal patients are diabetic. A good number of them are pre-existing diabetics. But the way we pick them up is with a good screening. Screening is a must. So in our prenatal package which we offer to our patients, we have HbA1c levels checked in the first trimester, as well as a fasting. And the development of GDM is an ongoing process. It may not happen in the first trimester when you pick up, but as the pregnancy advances, the metabolic pressures of the growing fetus, it exerts on the mother, makes them go into a diabetic state. So we have to do a screening, and that screening could be either a 1-stage screening or a 2-stage screening. 1-stage screening, irrespective of the prandial status, we give 75 milligrams and do a blood sugar at the end of 2 hours, and if it is more than 140, then we go for a full oral GTT test. And now comes the recurrent pregnancy loss. And this is a group which is a special group by itself. And it is better left to the care of a specialist in that field to pick up what is the reason. And as I told, a good number of them are autoimmune, though a large chunk of them are unexplained. And the other important thing is the anatomical factors. By anatomical factors, I mean Mullerian malformations of the uterus, cervical factors. And there comes the importance of measuring the cervical length. So as early as the first trimester, we start the screening, especially in a woman who gives previous history of multiple mid-trimester abortions or preterm birth. All we need to do is to measure the cervical length. And as long as the cervical length is about 2.5, we don't have to worry. And as the woman comes for the scanning in the first trimester for her fetus, and then in the second trimester, these are all the telltale signs. The sonologist can pick up and then tell us. The cervix starts opening up from the internal os, and when we can see this herniation of membranes into the cervix, that is the time we have to go in and then just put in a stitch over there to prevent this pregnancy from getting aborted or go for a preterm labor. So all you need to do is to put a stitch. Most of the times a simple McDonald stitch should be more than sufficient. And when you look at the cervix, anatomically it has got 2 parts. One which dips into the vaginal canal, and the one which is above that. A woman who has a cervix which is less than 2.5, most of the times a simple McDonald stitch should be more than enough. But for someone who has, in spite of the McDonald cerclage, has had repeated pregnancy failure, we have to go a little higher up, and for that we have this Shirodska stitch which can be done from the vagina. We just have to cut open the the fornix, both the anterior and the posterior fornix, and go as high as possible and then do it. Whereas the real sphincteric action happens at the level of the internal os, and when then these 2 procedures have failed, it doesn't mean that is the end of the world, and then we can go laparoscopically both during pregnancy and in the pre-pregnancy time, and then go in for a cerclage. And sometimes we do get patients referred like this. That's the cervix, and we can see the membranes bulging through it. And that is not the end of the world. We still can give these women a chance. And this needs a gentle both a pharmacological manipulation and a surgical manipulation by decreasing the intrauterine pressures by giving tocolytics, and with our anesthetic helps, friends giving a proper uterine relaxation, we gently pushing these membranes inside and then do the stitching. And many times we have saved these high-risk pregnancies which have happened after ARTs and all by doing this kind of a stitch. And many times what happens is when this kind of a clinical scenario is seen, the physicians, they just give up. We can still give a try, though I wouldn't say it is 100% successful at this stage. Ideally it should be done before it reaches this level. Even at this point of time, when we do the appropriate treatment, nearly around 75% of the pregnancies can be saved. So the best practice advice is we have to look for the cervical length, and in patients who are at risk, either we do a pharmacological manipulation like giving progesterones or do these stitches which I had just mentioned. And whenever we have a patient with preterm labor, as family physicians, what we need to understand is that this preterm baby is not everyone's cup of tea. And this group of babies, they need special care, and neonatologists need to be around. And the best way to transfer the baby from a peripheral center to a tertiary care center is an in utero transfer, we say, because there is nothing which matches a uterus. The blood flow, the oxygenation, the nutrition, all these things, there's nothing to match a uterus nature. So for this reason, it is better to transfer the baby with the, in utero to a tertiary care center. And before transferring a patient, we need to give some tocolytics. And one of the agents which is quite helpful is a magnesium sulfate. And magnesium sulfate, I just put it here. There are many drugs, but then I just wanted to share this information. Magnesium sulfate is not only a good tocolytic, it just prevents many of the prenatal complications like intraventricular hemorrhage, necrotizing enterocolitis, apart from giving a steroid. Steroid also is very, very important when a woman who goes into preterm labor, because with with either dexamethasone or a betamethasone, there is enhancement of the fetal lung maturity, and this is what a baby who is at a threat for a preterm labor needs. So friends, don't you think that when we identify the pregnancy which are at high risk as early as 12 weeks with all these factors like a proper history taking, a proper physical examination and a proper screening, we can always pick up the group of people who need a specialist care as early as the first trimester and leave that group of people to the specialist, and the rest, instead of going around putting a stress on our tertiary care centers, are very well managed in the peripheral PHCs. Thank you.
Good morning all. Thanks Madam for the excellent presentation. All topics are fully covered. Madam stressed the need for physical examination, identification of risk factors and proper referral. Also, counseling can be given during ANC period regarding contraception and breastfeeding. I hope this topic will be very useful to all practicing family physicians as well as PG students. Thank you.
Thank you for enlightening us on antenatal care. I think it's a very vast topic to cover in 40 minutes time. Ma'am, can you enlighten us on vaccination in pregnancy, which will be very useful for us? Which are the vaccines to be given in the first trimester, second trimester, or whenever the patient walks in?
Yeah, see the standard protocol is we all give tetanus toxoid. I think that is happening across all PHCs. But even there, instead of the second dose of just giving a plain TT, it is better to give this coverage for diphtheria and whooping cough. And the Tdap vaccine now is available. So we are advocating that in the third trimester. We give it at around 28 to 30 weeks. So because this followed a recent episode of whooping cough in Kerala a few years back. A good number of babies were having this immediately at birth. And when the mother is covered in the antenatal period with these vaccines, definitely the neonate also gets protected until the neonate gets vaccinated itself and then forms its own antibodies. So that is one thing. This is a standard thing. But as and when the need arises, say for example, we had this pandemic and then many of the antenatal women, though they were reluctant with counseling, they took the vaccine. And specifically, say the other things which we face is rabies. Many a times patients come to us with dog bites. And the risk of the vaccination and its side effects is much less compared to the risk of the disease. So whenever the benefit is more, then we need to give the vaccination.
Would you recommend flu vaccine regularly for all?
Not necessary. Okay. We don't do it in our regular practice. Okay.
We see a lot of ANC mothers coming with ANC scan showing some abnormalities. What to do, when to refer, especially renal abnormalities. Renal abnormalities, renal ectasis. We don't know what to do, how to counsel.
That's actually a very difficult topic, sir, because embryogenesis is, the evolution of the organs itself is a high, it's a very complicated topic to understand and practice. And for that only we have this specialty of fetal medicine coming up. So now the fetus has been recognized as an individual itself, apart from the mother. And that is why the need for this fetal medicine is there. And coming to this, the etiopathology of the multiple anomalies we see, it could be either one system disease or it could be a multi-system disease. When it is a multi-system disease, usually it could be a part of a syndromic association. And sometimes the organogenesis or the external morphology could be normal, but the functional problems could be there, especially with inborn errors of metabolism. We don't pick up any anomaly as such, but there could be a family history of previous neonatal deaths, and that is the importance of taking a proper history. And when there is, most of the times what happens is when the newborn is dead, the patients, they just throw away the previous baby's records. So we don't, many of the vital medical records are destroyed. So, but then this needs to be insisted. And so all these things have to be kept, and then they throw, not most of the times they'll be in a position to pick up, but then it throws some light, like what could be the problem there. And if it is a single system disorder, then we need to say, so for example, somebody has come with a diaphragmatic hernia. That is extremely compatible with a neonatal life, extrauterine life, if properly identified and then operated at the right time. Recently, I have a patient right now in the ward wherein the child had ileal atresia. It was picked up in the antenatal period, and most of the times what we do is when there is an anomaly like that, we try to give them a vaginal delivery as much as possible, unless the indication should be only maternal for us to give her a cesarean delivery. So these are all the different thought process which goes through our mind as an obstetrician, because when there is an anomaly and the child needs to undergo a surgery in the immediate neonatal period, even in the best of centers, sometimes the results may not be good. Finally, you take a baby out of a C-section and the baby doesn't survive, then it becomes a problem. So the counseling needs to be given according to the problem which is there, and there are a number of specialists need to be involved. Say for example, a cleft lip baby, the cleft lip comes, then it may be an indicator of trisomy 18 also. And if it is isolated, then it is a correctable thing. So we need to give more emphasis on the imaging. In these, whenever there is a single anomaly picked up, then the imaging becomes more important. We have to pick up other anomalies which are there, and multiple consultants need to come in. A neurological problem picked up, then I may have to take the help of our neuro colleagues to counsel them, or a pediatric neurologist to counsel them. Same way, as I told you, this ileal atresia, I have to get them counseled by our pediatric surgeon. So all these things happen. So we cannot just say with one word what needs to be done. So it is a multidisciplinary team approach needs to be taken.
Hello, Padma, this is the last question.
Yeah.
I'm so happy to see my schoolmate, my UG mate, make such a good presentation at this meeting. Yeah. Anyway, Padma, what about LMW in APLA mothers? Low molecular weight heparin?
Yeah. Sindhu and Bindu are quite close to us. They are twins. And I mean, it is just to be off the track. When they just joined, we studied from 11th together. And it used to be a quiz, like who is coming into the class, Sindhu or Bindu. And we have our pleasant memories of our school days and college days. And coming to our question, we do give low molecular weight heparin. See, basically because APLA is a vascular disease, it's a vasculitis. And as I counsel my patients, the only organ which is highly vascular in the body when a woman is pregnant is the placenta. And when the disease which basically affects the placenta, vessels, naturally there will be extreme amount of thrombosis within the placenta, and we need to address that. So low molecular weight heparin has an important role. Apart from aspirin, we do put them on low molecular weight heparin also, and that needs to be continued until delivery. Though aspirin we stop at around 36 weeks just prior to delivery, we continue the low molecular weight heparin until the day of delivery. We just stop it 12 to 24 hours prior to the time of delivery, and we continue it in the postnatal period also, because these women are highly prone for venous thrombosis and even arterial thrombosis in the postnatal period. Thank you, Sindhu.
Is there time for one more question? Yeah, just the role of vitamin D3 in preventing complications in pregnancies, because that's something that all GPs can easily follow, and how often and when it should be given.
Yeah. See, basically vitamin D3, we know it's a sunshine vitamin. Just an exposure to the sunshine is all that is needed for our own body to produce the adequate quantity of vitamin D which is needed. Well, that is well said for women from the villages and other things. In the cities, most of the times they are in closed environment, and especially like people who are working in in a closed environment, the exposure is very low. So these are the people who are at high risk. And though the pharma industry is trying to push in vitamin D3 is very, very important, and then do that, I sincerely feel most of the times my prescriptions are very short. They have only an iron and a calcium, nothing more than that. But the woman is having other medical factors, then those kind of prescriptions come in. And even this calcium is, we give it because we know not only during the antenatal period, even in the postnatal period also, the mother when is lactating, there is a good demand for the calcium. And for that reason, we give the calcium. And none of the preparations which are available in the market right now, they are marketed with only plain calcium. Most of them, 90% of them have added vitamin D3 into that, and no harm in taking that 1000 international units which is available in most of these preparations. But a word of caution, I have seen people for the sake of taking vitamin D3 taking weekly 60,000 international units weekly and all, because somebody has told that and then do it. Vitamin D3 is a fat soluble vitamin. It gets stored. And any fat soluble vitamin, we need to be careful while we give it in the antenatal period. Unless there is a real strong indication, we should not be initiating a vitamin D3 therapy per se. But then of course there are a group of people who are osteoporotic or osteopenic, and if they have symptoms related to that, we can do. And another place where calcium plays a role is many of these women, they tend to have, pregnant women, they have cramps, and calcium helps with that too.
Thank you so much for patiently answering all our questions, ma'am. I know antenatal care topic never ends
I know it's
with the
a
discussion.
vast thing. When Pranita told me, I was thinking, what do I talk from the whole Williams?
Yeah.
I know I have not done real justice to the topic, but then when I contemplated, I thought, okay, let me just tell this.
Okay. If there are any further queries, we'll, with ma'am's permission, we'll share the email ID. We can pass on the queries to ma'am's email ID and we can get the answers.
Sure, it's my pleasure.
Sure. Thank you so much.
Thank you.
Thank you, ma'am. Now I request Dr. Purushothaman sir to honor the speaker and the chairperson.